Good afternoon, everybody. This afternoon, I present on behalf of the BEST-CLI investigators. So the BEST-CLI trial was sponsored by the National Heart, Lung, and Blood Institute, and additional support was provided by industry and physician societies. It was a prospective, randomized, multi-center, multi-specialty pragmatic trial whose goal was to compare clinical effectiveness, functional outcomes, and cost in patients with CLTI infrainguinal PAD who are candidates for both open vascular surgery and endovascular therapy. Those patients had their great saphenous vein imaged using duplex, and then imaging of index leg arteries occurred. And then two physicians, one credentialed in endovascular, one in open surgical, decided whether or not that patient was an adequate patient to be entered into the trial. The trial was a conglomerate of two parallel trials. Cohort 1 are patients who had adequate single segment saphenous vein. Cohort 2 are patients who did not, and so if randomized to surgery, any conduit could be used. The patients were stratified based on clinical presentation and anatomy, and then randomized one-to-one to either endovascular surgery or endovascular therapy. And decision on the techniques was led up to investigators, hence the pragmatic nature of the trial. So the hypothesis for cohort 1 was that bypass with single segment saphenous vein would outperform endovascular therapy, while in cohort 2, that endovascular therapy would outperform bypass with alternative conduits. The primary endpoint was male or all-cause death. Male included above ankle amputations or first major reintervention. MACE was our safety endpoints, and as you can see, both first major intervention, MI and stroke, were adjudicated by CEC. Next slide, please. Here are the results of cohort 1. So there were 1,434 patients in cohort 1. The median follow-up was 2.7 years, and the maximum follow-up was 7 years, and the crossover rate was less than was anticipated. The baseline demographic and clinical characteristics were similar to and representative of what one would expect to see in a cohort of patients with CLTI. Here are the main findings. The primary endpoint occurred in 42.6% of patients in the surgery arm and 57.4% of patients in the endovascular arm. With a hazard ratio of 0.68, surgical bypass was associated with a 32% reduction in male or all-cause death. This finding was driven by significantly more first major interventions in the endovascular arm. There were 74 above ankle amputations in the surgery arm and 106 in the endovascular arm, which translated to a 27% reduction in amputations in the surgery arm. There was no difference in all-cause death. This Kaplan-Meier curve of the primary endpoint shows that surgical bypass significantly outperformed endovascular therapy. This difference was evident early and persisted throughout the course of the trial. The absolute risk reduction at median follow-up of 2.7 years was 10.3%. Patients randomized to endovascular were significantly more likely to have first major interventions and significantly more likely to have above ankle amputations. There was no difference in death. With respect to total major interventions, over the entire course of the trial, the incidence rate in the surgery arm, in the endovascular arm, was more than twice that in the surgery arm, and the curves appear to diverge. With respect to MACE, both at 30 days and over the course of the trial, there was no difference between surgery or endovascular. Here are results of cohort 2. There were 396 patients in cohort 2. The median follow-up was 1.6 years. The maximum follow-up was 5.1 years. And there was no significant difference in the primary endpoint in cohort 2 patients. There were more major interventions in the endovascular arm in cohort 2. BEST had limitations. It was a pragmatically designed trial, so there's possible selection upper bias in enrollment and intervention. Equipoise and eligibility were determined locally and likely to be variable. There was procedural heterogeneity. Cohort 2 was likely underpowered. Anatomic complexity is yet to be evaluated, but we will be evaluating that in the very near future. The percentage of female patients was lower than targeted. The use of paclitaxel-coated balloons and stents during enrollment was likely affected by the Katsanos meta-analysis. In summary, surgery was more effective than endovascular therapy among CLTI patients who had adequate saphenous vein and who were eligible for either strategy. There was reduced male or all-cause death, fewer major amputations, and fewer major interventions in the surgery arm. In patients who did not have adequate saphenous vein, there was no significant difference in the primary efficacy endpoint. There were no differences in perioperative mortality or MACE, and mortality and MACE were similar over the course of follow-up. In conclusion, then, In CLTI, both surgical and endovascular strategies are effective and safe. Bypass with adequate saphenous vein is a more effective strategy for patients deemed suitable for both strategies. Patients who are candidates for limb salvage should undergo an evaluation of surgical risk and conduit availability. Bypass with adequate saphenous vein should be offered as a first-line treatment option for suitable candidates with CLTI as part of a fully informed shared decision-making. Level 1 evidence from BEST-CLI does not support an endovascular first approach to all patients with CLTI. In fact, it does support a complementary role for open and endovascular strategies and highlights the need for expertise in both for optimal care of these patients. If you'd like to learn more about this trial, please come to our meeting on Friday at 1 p.m. Thank you.